Good afternoon and a warm welcome to everyone. We have been conducting cutting edge webinars every week since over a year now. It is done by the Pune Obs-Gynae Society along with various societies from all across India with the aim of spreading medical education and having everyone have a same or systematic viewpoint for every single topic. Today, we are having again two very interesting topics by two eminent speakers, and we have a whole list of eminent faculty joining us today for these webinars. With this, I would like to start the webinar with a small prayer because we always take the blessings of Almighty when we start any sort of academic program. So I would request everyone to have 2 minutes of silence and listen to a small prayer, and then we can get ahead with the rest of the session. Can we have the prayer, please, Mr. Aman? Mr. Aman, can you play the recording?
I think the audio is not good. Audio is not there, Mr. Aman.
Hello.
Yes.
Yes, ma'am.
The audio of the
Any
prayer is not
problem from your side? There was no audio with the prayer. Is there any problem? Or can we go ahead?
So unfortunately, we're just having a little bit of technical difficulty. We'll just try it once again.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you so much. I would now request Vaishali ma'am to introduce Dr. Aarti Nimkar, President of POGS. And I would request Aarti madam to say a few words.
No introduction needed, Aarti.
No, let me. She wants me to introduce you, ma'am. So it's a great pleasure for Pune Obstetric Gynec Society to welcome Chandrapur OBGY Society and Bhandara OBGY Society. And just with one phone call, Dr. Manisha Ghate, though they are very, very busy with AMOX preparation, agreed for this webinar. And here we are at the great academic forum to do cutting edge webinar, which POGS has been doing every Tuesday, 4 to 5 p.m. And this has been started by Dr. Minu Agarwal. And we have eminent guest of honors today. We are truly, truly blessed to have such great academicians. Dr. Charuchandra Joshi, sir, is a true friend, patron, advisor for every member of POGS. And Dr. Kirti Sane, whom we are so fortunate to, we will be receiving Madam's blessings. So to introduce our very dynamic President of Pune Gynec Society, Dr. Aarti Nimkar. Madam is not only senior well-known gynecologist, but she has many, many interests apart from practicing gynecology. Of course, she practices at Suman Nursing Home at under guidance of Dr. H.N. Fadnis and Dr. Raiturkar, madam. She's been doing good obstetric work, and she has worked. She's a very enthusiastic hiker, fitness freak, gym rat, what we call it, fitness enthusiast, a very good dancer, and very artistic, very graceful, very loving, caring person. And now today she's at the helm of POGS as a very dynamic president of POGS, and Madam has won many awards. Best Branch Award from IMA-MS, Best President Award from National IMA, Dhanvantari Lokmat Award in 2021, IMA Pune Doctors Day Award in 2023, and she follows all her hobbies and passions with endless energy. Madam, welcome, and for the webinar, let's proceed.
Yeah. Thank you, Ashwini. Can you hear me? Thank you, Ashwini, for this prolonged introduction. Yeah.
Vaishali.
Vaishali. Yeah. Thank you, Vaishali. Today we are having the cutting edge, and this cutting edge webinar is going on since 1 year, and now it become a routine at every Tuesday. Like we are waiting for the Tuesday when Tuesday is coming, and we see the program of the cutting edge webinar. And this is for the introduction of the Vaishali to the each and every branch of the Foxy, as she is contesting for the VP position in the Foxy. So everybody will know you, Vaishali, and they will remember you when they are voting. Yeah. And I welcome our special guest, Dr. Charu Chandra Joshi, because he's a good friend. That's why every time I call him Charu. And our guest of honor, Kirti Sane Madam, she's the past president of the Chandrapur OBGYN Society and now become a good friend of the POGS also now. And first lecture will be by the Vaishali on the manual to manage the shoulder dystocia for the every obstetrician, because every obstetrician once in a life, at least once in a life, face this difficulty to remove the big shoulder when the vaginal delivery is done. Head comes out and shoulder stuck up there. So that is a real nightmare. And chairperson for her are the Dr. Manoj Aglave from the Bhandara. He is the secretary of the Bhandara OBGYN Society, and Dr. Sarla Agarwal, past president of the Bhandara OBGYN Society. And second session will be by the Manisha Ghate, intrapartum care for the joyful motherhood. And chairperson, she is the secretary of the Chandrapur Society. And chairpersons are the Dr. Nirja Naidu and Dr. Kalpana Gulaude from the Chandrapur Society. Gulaude is AMOX organizing secretary of the AMOX, and Dr. Naidu is the VP of the Chandrapur IMA. She is working in the IMA, that's why we know her better since long. So welcome you all for this webinar, and I think everybody will enjoy. And Dr. Aarti will conduct further.
Yes, sir. Thank you so much. I would request now Meenakshi Deshpande ma'am to introduce our guests of honor.
Yeah, thank you. Welcome all. At the outset, let me welcome all of you, all the esteemed faculties, chairpersons, guest of honors to this prestigious webinar of POGS, which we are conducting from about 1.5 years. And we would like to welcome all of you to this webinar of cutting edge webinar today. Secondly, I would like to introduce our guest of honors today. I would really heartily welcome Dr. Charu Chandra Joshi sir and Dr. Kirti Sane madam from Chandrapur. Can I have their CVs, please? Yeah. So we are having Dr. Charu Chandra Joshi sir as our first guest of honor, who is a consultant in obstetrics and gynecology in Pune, practicing in Pune since 1984. He was the president of POGS twice in his lifetime, in 11-12 and in 16-17. And his areas of interest are surgical gynecology, disorders of pregnancy, and of course, learning and teaching postgraduate students is his passion. So I would welcome sir to say a few words.
Thank you, Meenakshi, for those words. Thank you, Aarti, Vaishali, and all the organizers. Two Aartis. One is the senior most and the other one is the junior most Aartis. They are running the show for us today. And it's always my pleasure to take part in all the academic activities, especially when my dear friend Vaishali is there. And as Aarti mentioned earlier, she is our poster girl for the post of Vice President of FOXI. And with her eloquence, with her knowledge, with her oratory skills and other qualities, I think she's going to make a wonderful Vice President FOXI next year. So that is enough. Let's start with our proceedings.
Yes, sir. Thank you very much for your blessings and best wishes.
Yes,
I would
sir.
like to introduce our second guest of honor, Dr. Kirti Sane, ma'am. Can I have a CV, please? Kirti Sane, madam, is the past president of, I think she's of PO Chandrapur Obs Gynae Society and also of IMA Chandrapur. She's a certified gynecologist with over 35 years of experience in providing patient-centered care. She is dedicated to advancing women's health through evidence-based practices. She is a bachelor MBBS and a DGO and consultant gynecologist practicing at Chandrapur. She's a life member of IMA and of course FOXI. And we welcome you, madam, as our second guest of honor, and welcome and request you to say a few words and give your words of blessings. Madam, you're mute.
Hello.
Hello.
Hello, everybody. Distinguished guests, organizers of Cutting Edge Webinar, Pune Obstetric Gynae Society President Dr. Aarti Nimkar, Secretary Dr. Meenakshi Deshpande, today's esteemed speaker Dr. Vaishali Chauhan, Dr. Manisha Ghate, President of Chandrapur Obstetric Gynae Society, President Secretary of Bhandara Society, esteemed chairpersons Dr. Aglave, Dr. Gulwade, Dr. Naidu, Dr. Agrawal, and today's guest of honor Dr. Charu Chandra Joshi, past president, mentor, and key person from Pune Obstetric Gynae Society, MOC Dr. Aarti Evle, and all other present members. Today, I am privileged to be a part of this important webinar as a guest of honor. I would like to begin by commending the organizers for bringing all of us together to discuss shoulder dystocia and management of manuals and intrapartum care for joyful motherhood. Both the difficult topics will be made easy by our speakers. This webinar serves as testament of power of collaboration and knowledge sharing, which are critical in addressing the complex challenges we face in healthcare today. Let us remember that the heart of medicine lies in its purpose to heal, to elevate suffering, and to improve quality of life. My all the good wishes are with the organizers and participants of this webinar. With
Yes,
Pune
thank
and
you very much.
Amravati Society,
Yeah.
with Pune and Amravati Society, we Chandrapur Obstetric Society is participated in very successful Anand Exchange Conference in July 24. That was a great experience with Dr. Meenakshi Deshpande and Pune team. That proved collaboration with other societies improves fellowship. On this platform, I take opportunity to invite you all for 38th AMOX conference, which will be held on 14th, 15th, and 16th February 25 at our own Chandrapur. Our society has hosted 9th AMOX in 1994. After that, a long time, we are fortunate to get chance to organize AMOX 25. Our organizing chairperson, Dr. Manisha Ghate, organizing secretary, Dr. Kalpana Gulwade, organizing treasurer, Dr. Nagina Naidu, and our team is working very hard on each and every front to make this conference a great success. As a founder member of this society and past president, I request you to please register as early as possible so that opportunity to visit Tadoba Safari will be sure. You will experience our hospitality and warm welcome. I assure this conference will be very memorable to you all. Once again, I request you to please register and do come to Chandrapur. I take your leave. My all the best wishes for this long-going webinar. Thank you so much.
Yes, thank you, madam. Thank you for your blessings and also for your generous invitation and hospitality of Chandrapur. We are already knowing and we have experienced it also. So we will be surely attending Chandrapur AMOX. You be rest assured. Also, we would now here like to extend our
Large number,
request.
madam. With large number.
We would like to
I
extend
was
my
just-
request to
You all
support
will
Dr.
definitely come.
To support
Madam,
Dr. Vaishali Chauhan as a
madam.
POGS member who is contesting for Foxy VP elections throughout
Okay,
both
okay.
of your societies, for Chandrapur also and Bandara also. So thank you so
Okay,
much.
okay.
And rest assured we'll be surely attending amongst. And also here I would like to extend my invitation to come for the POGS 33rd annual conference scheduled on 21st and 22nd of December. It is done with the 6th International Conference of Pearls and Pitfalls of Endoscopy and ART. So we have teamed up two conferences together on 21st and 22nd of December at Pune. So we would like to invite all Bandara as well as Chandrapur people to come over, register, and even you can announce your conference over there also. So thank you so much. Over to
Thank
Dr. Aarti. Yeah.
Thank you, Meenakshi, for saying, for propagating my candidature. And I would like to thank Dr. Sane. Madam, your words, wishes and blessings. We are truly overwhelmed with your wishes. Thank you very much. And with your kind invitation, we are sure to come POGS in large numbers to AMOX. We have seen what Chandrapur Society did last, and the entire performance, not only culturally but academically, what a vibrant, dynamic society Chandrapur Society is. And we look forward to, under your leadership and Dr. Manisha, who is the organizing chair, Dr. Kalpana, Dr. Nagina, and all the leaders of Chandrapur. I'm sure it's going to be a fantastic AMOX. So thank you very much. We'll be there. And sir, Charu, sir, I am, and all of us at POGS are truly, truly blessed with your wishes, your guidance, and you're there for us. You're just a phone call away at every step. Wherever there's an obstacle, sir is there for us. And because of sir, POGS, our entire society is strong because sir is there for us. Sir,
It's always my pleasure. Thank you.
yes, I would also like to mention sir is a brilliant academician, and his lectures which he takes for the undergraduates, postgraduates are like packed, and he does this in spite of his busy schedule late at night, where the undergraduates literally there's no place to sit for them. And so for today's webinar, your expertise and advice would be very useful. So thank you very much to both our
Thank you.
guests.
You're welcome.
Thank you.
Thank you, ma'am. So with this, we'll proceed to the first session, for which I would like to invite our chairpersons. Can I have the slide, please? Can I have the next slide, please? No, we'll have to go. Please show me Dr. Manoj sir ka CV. Yes. So I would like to invite Dr. Manoj sir. He is consultant gynecologist and laparoscopic surgeon. He has finished his MS OBGY from Sion Hospital, Mumbai, and he is ex-associate professor in IGGMC, Nagpur, and secretary of Bandara OBG Society. So welcome. Can I have Kalpana Madam's CV now? Kalpana Madam is consultant obstetrician and gynecologist and endoscopic surgeon at Chandrapur. She has been the organizing secretary of AMOX 2025 Chandrapur, advisory member, district PCP and DT committee. And ma'am has received previously the best secretary state and national IMA award in 2023-2024. Ma'am, it's an honor to have you here. I would request Manoj sir to kindly introduce Vaishali Chauhan ma'am, our first speaker for today.
Good evening. Thank you for giving me the opportunity to share the session. It's my pleasure to introduce new speaker, Dr. Vaishali Chauhan Madam. She is a clinical director at Cloud9 Hospital, Kallari Nagar, Pune. She is the director of Savni Clinic Women's Health Center. She is the vice president elect of Pune OBGYN Society and chairperson of Perinatal Committee, Foxy. She is the honorary general secretary of Pune OBGYN Society 23-24. She has many publications and chapters in various books and has contributed to many focused and chapters in international publications.
Thank you, sir.
She received the award in Senior Mission Award 2017, Samaj Mission Award, Vaidya Gaurav Puraskar, Lokmat Award, Inspiring Gynecologist of West India,
Thank you,
Award
sir.
Okay. And the further item, I will request to Chavan madam to start with talk on manuals in shoulder dystocia management.
Thank you very much, sir, for your kind invitation. And we are truly thankful to Bhandara OBGY Society for teaming up with us for this webinar. So I'm going to just share my screen now. Is my screen? Yes. Just a minute. Yeah. So my topic today is a very clinical topic. That is macrosomia and birthing difficulty, the maneuvers that are required various maneuvers for shoulder dystocia. So when we talk of shoulder dystocia, it's a nightmare, like Aarti madam said, for each and every obstetrician. And it would be really useful, if we can predict beforehand that, yes, this baby may go into shoulder dystocia. And that is why we are talking about macrosomia, because it is these big babies, large babies, which the head comes out and the shoulder remains impacted and there's shoulder dystocia. So is there any way that we can predict? How do we look out for such macrosomia, babies with macrosomia? So what is the definition? It means large for gestational age, or where the birth weight is equal to or more than 90th percentile for a given gestational age. Or macrosomia also implies if the birth weight estimated for Indian population is more than 4 kg, or there could be estimated circumference of expected fetal weight divided by abdominal circumference, which is more than 95 percentile. And there have been many RCTs and systemic reviews, and they have said it's really very difficult to predict that this particular baby may end up with shoulder dystocia. And they have said the best ultrasound predictor of shoulder dystocia was not the estimated fetal weight or the how abdominal circumference, but it was a difference in the abdominal and biparietal diameters. And if that difference is more than 2.6 or equal to 2.6 centimeter, then yes, it could be a good predictor for shoulder dystocia. Also, we need to look for any in any conditions in which the baby may have macrosomia, like maternal conditions, pre-existing diabetes, GDM, prior history of macrosomia, maternal age is more, higher parity, post-term pregnancy. And why are we so worried about shoulder dystocia? Well, we know that it leads to a lot of complications, like fetal complications that could be asphyxia, brachial plexus injuries, shoulder perinatal death, and even for mother, there could be PPH and third, fourth degree perineal tear. Such a big baby coming out could lead to not only fetal complication, not only for the baby, but for the mother as well. And fetal morbidity, when we talk about shoulder dystocia, there are injuries associated with shoulder dystocia, which may end up right till the fracture of the clavicle. And there's damage to the nerves of the brachial plexus, leading to Erb's paralysis. But it's, heartening to know that even if there's Erb's paralysis, by the age of 1 year of age, 80 to 90% usually resolve. But persistent injury may be there if baby is bigger. And of course, there could be hypoglycemia. Baby later on goes on having obesity and so on. So if you suspect that, yes, this is a big baby, may land up with shoulder dystocia, it's very important to get a senior obstetrician review. How do you estimate if there's arrest in the descent in the second stage or there's prolonged second stage of labor? Then we know, yes, there is some kind of problem here, and it's very important to be alert and to anticipate. And it has been said, there have been many studies that prolonged first and second stages of labor are common when macrosomia is present. So there comes the thought that is it better to induce labor before 39 weeks of pregnancy? Many a time our patients say ki, we are eating a lot of protein खा के बच्चा बड़ा हो गया है, jaldi karo delivery, or I may end up with a cesarean. So is that true? Should we be inducing patients before 39 weeks of pregnancy? And so let us see what various RTCs and what do the guidelines say. So they have said, as such, there's no evidence to support induction of labor just to avoid macrosomia. So coming to the talk about shoulder dystocia. Now, what is shoulder dystocia? Shoulder dystocia means failure of the shoulders to deliver after the birth of the head, after the delivery of the head within 60 seconds. It means that the head has come out and then the shoulder, as it is seen in this video, the shoulder goes and gets impacted. If it's anterior shoulder, it gets impacted below the pubic symphysis. And because of that, there is an injury here to the brachial plexus, which you can see here. And because of this position, there are subsequent complications and brachial nerve injuries. And this is what is shoulder dystocia. That is failure of shoulders to deliver after delivery of head within 60 seconds. And in shoulder dystocia, it's also said by definition that you require additional obstetric maneuvers to deliver the fetus after the head has been delivered. And mostly shoulder dystocia, the anterior shoulder gets impacted below the pubic symphysis. And if it's a posterior shoulder, it may get impacted near the sacral promontory. There is associated maternal morbidity. There could be 4th-degree perineal tear and, of course, brachial plexus injuries. What is turtle sign? Recently, I had gone for VPCon conference at Bhubaneswar, and there was a quiz going on about shoulder dystocia. And most of the students could identify the turtle sign. So this is the typical turtle sign. What really happens is the head comes out, and then this anterior shoulder here, in this animation, it is shown that it gets impacted below the pubic symphysis, but the contractions are ongoing. And the contraction, because of the contraction, what happens is the head gets pushed out, but the shoulder remain there. Again, with subsequent contraction, the head get pushed out, but the shoulders remain there. There is no progress, and this is known as turtle sign. And this here you can see in the animation is a very clean picture, but in real life, what really happens is a picture like this, and this indeed is a nightmare. You see that the head is stuck and there's panic everywhere. There's blood, the woman is screaming. And this is something that we all as obstetrician, we do not want to face this situation. So when this happens, as obstetrician, what can we do? And then there are simple maneuvers which we can do, which can help us relieve. First of all, you need to call for help, because to conduct these maneuvers to deliver a shoulder dystocia baby, you need help. Help right from assistant doctors, senior doctors, if they are around, that is the best thing. Plus you need staff, sisters, even the maushis to hold the legs. So as much help as you can get, it's very important. Please do not manage shoulder dystocia on your own single-handedly. You need help. Second thing, do not give Mofundal. More fundal you give, somehow you'll be able to remove the baby. No, once you have diagnosed it's shoulder dystocia, once turtle sign is present, pushing, giving fundus is not going to help. At the same time, do not pull from below. The same thing, it is not going to disimpact. The shoulder which has lodged there is not going to come out by pushing or pulling. Important to drain the bladder. Give a liberal episiotomy. Since this is a bony impaction, as such, episiotomy is not going to help relieve the shoulder dystocia, but it helps us conduct the maneuvers in a better way. Now let us look at the various maneuvers. First of all, take the patient to the edge of the table, clear the infant's nose and mouth, and no fundal Genders episiotomy, and then Mac-Roberts position. We all are familiar with Mac-Roberts position. That is hyperflexion of the legs and abduction of the legs. And suprapubic pressure. In this, you can see suprapubic pressure is given. And suprapubic pressure is given in such a way that this impacted shoulder, which is in anterior position, is turned inwards. It becomes inwards and it comes in the oblique position. So when you put the patient's abduct and adduct the legs, flex and abduct the legs, what happens is the pelvis tilts and the pubic symphysis becomes more horizontal, and it helps in the shoulder delivery. It improves the diameter. And this is the simple video. These all videos are taken from the net, and this is how it happens. You flex the mother's hips, and at the same time you abduct. And for flexing and abducting, you need additional help. And with that, what happens is this impacted shoulder suddenly is relieved because the diameter has increased. So with a simple MacRoberts maneuver, that is flexion, abduction, and even suprapubic pressure, 50 to 60% of shoulder dystocia cases are relieved. And you should do each maneuver only for 30 to 60 seconds. If it does not work, you have to go to the next step. And this is Rubin's 1 and Rubin's 2. Rubin's 1 is when you push anteriorly through the abdominal wall. Try to push the anterior shoulder and make the anterior posterior diameter into oblique diameter. This is RCOG guidelines 42. Or Rubin's 2, when you accomplish the same, but you do that vaginally and you push the anterior shoulder from behind the pubic symphysis and try to make it oblique. So the principle here when you do maneuvers is just to maneuver and change the position of the baby so that you dislodge the anterior shoulder, or if it's posterior shoulder, you dislodge from the AP diameter, you make it to oblique diameter. Anything that changes the diameter can help the baby to deliver. Wood's corkscrew maneuver. Now this is also a maneuver where you rotate the baby and baby is delivered out. So basic principle is reducing the diameter, disimpacting. Here you can see that pressure is applied to the front of the posterior shoulder. From 2 fingers are used, and by both the baby is rotated. One is behind the anterior shoulder and second finger is in front of the posterior shoulder, and you turn the baby and then deliver out. The same can be done when the position is here. So the same principle, irrespective of whether anterior shoulder is impacted or posterior shoulder, you can use the same principle where fingers are applied posterior and you rotate the baby and deliver. So these are all rotational maneuvers where you disimpact the impacted anterior posterior shoulder, make it oblique, and then deliver the baby. So this all looks very clean in animated videos, but when you're actually doing it, it's very important to remain calm and do not panic. There's another maneuver where you deliver the posterior arm. So you put in a finger, palpate for the posterior arm, and along the baby's body, sweep the posterior arm anteriorly over baby's abdomen, chest, and then remove it out. Minute one arm comes out, the diameter reduces, and it's easy to deliver the baby. Coming to Zavanelli procedure, it means Zavanelli is you have tried everything and you're unable to deliver the baby. So you simply push the baby partially, which has come out, push the baby in, and then do a quick emergency cesarean. So here is a very interesting video of Zavanelli maneuver, where the baby which had come out, you just push the head in very gently, and as soon as you push it in, you do an emergency Caesar immediately without wasting time. So these all maneuvers are very interesting. There's a shoulder shrug maneuver. When you shrug your shoulders, automatically the diameter reduces, the biacromial diameter reduces. So with the same principle, you put in and digitally try to shrug the shoulders like this and then deliver the baby. This is a Gaskins or all four position where patient is on all four, and what happens is there's 1 centimeter to 2 centimeter increase in the AP diameter of the pelvic outlet. And there's a very interesting video showing the same to make us understand better. And this is the Gaskins maneuver where the mother is on all four, and they say because of gravity also there's added pressure on the bony structure, and it stretches the pelvic ligament and it increases the pelvic outlet by as much as 1 to 2 centimeters. and that helps us to deliver the baby. So this is the Gaskin's maneuver. So we've been through all the maneuvers and talking about destructive surgeries which actually have no role in modern obstetrics right now, and I have never seen in my teaching learning days, also in college also, but it has been mentioned: symphysiotomy, or fracturing the anterior clavicle of the baby, or clitotomy, or something to complete the list. So it's very important that we train all our birth attendants, not only our budding gynecologists, young gynecologists, but everybody who is in the labor room. So drills are mandatory, routine drills, so that everybody is in touch. And there is a helper synonym, which is very important. Documentation is very important. H is call for help. Evaluate for episiotomy. L is legs, that is Macrobert's maneuver. P is external pressure, suprapubic. E is enter all the rotational maneuvers. R is remove the posterior arm. And R again, roll the patient to a hands and knees, that is the Gaskin's maneuver. And recently when I went to Bhubaneswar, this was the question which was asked, and this was a winning question, and the students could answer the helper mnemonic to help a patient in shoulder dystocia. So as obstetrician, is very important to anticipate which patient has fetal macrosomia and who may end up with shoulder dystocia. Also diagnosis and management, skilled and experienced, you need a obstetrician, neonatologist in the picture, and all these maneuvers preferably to do in the operation theater. And prevention, of course, plays a major role. So giving advice and during antenatal period, regarding diet, exercise, is so very important. So thank you very much for patient hearing, and I would like to appeal to all of you for your blessings and support for me for the post of Vice President Foxy, election year 2025. Thank you very much.
Thank you indeed, Dr. Vaishali. That was indeed a very illustrative and well explained nightmare, which I'm sure every gynecologist who has faced only knows that how to manage that. And it is actually a nightmare to see the baby going cyanotic and your fingers going numb. So very well explained. You have brought forth quite a few new points. 2.6 centimeters or millimeters was the difference was new for me. So thank you so much, and hand over to the MOC again.
Thank you, Dr. Kalpana, for your inputs. And yeah, truly it's a nightmare for when we are faced with such cases. Sir,
Vaishali?
I'd like to...
Yeah, may I make a few comments?
Yes, sir, please, sir.
Yeah. It was a wonderful presentation as always. And at the end of 40 years of my obstetric practice, all I can say is I would not wish this to happen to worst of my competitors. Because those of you who have gone through it will agree that what a nightmare or pain it is when you hand over a nice and chubby baby, a fresh stillbirth, dead as a doornail. So it should not happen to anyone. And generally it happens when you are least expecting it. Yes, there are risk factors. There are things you can, some things you can anticipate. Now, all those risk, you have beautifully explained those risk factors, but they are marred with the factor of not very satisfactory positive predictive value. So they may not help much. Now, as you pointed out, practicing drills are very important, but the drills must not be done with those rag dolls and bony pelvis because they are useless. And what you can do is with the mannequins and that is called as a high fidelity maneuvers, the real time size. But once again, you nicely pointed out that a real live patient is different from those models because the patient is shouting, resisting your manipulations, and there is edema, there is bleeding. Plus, timing is running out because head to body delivery interval, if it crosses 5 minutes, the chances of neonatal mortality are pretty high. So you must do the practicing in simulation labs and not with the rag dolls and bony pelvis. Another thing I want to point out is the BPI, that is brachial plexus injury in the newborn. You rightly said that most of them resolve up to the age of 25 perhaps, but just 10% remain permanent. And in Western countries, it is the one of the commonest reasons for medical legal litigations. Now, the same RCOG guideline has also, guideline number 42 has also described that since it is the posterior shoulder which is generally less affected, or if you pull the posterior shoulders, it is less likely to have brachial plexus injury. If you document that supposing a patient comes with a brachial plexus, permanent brachial plexus injury and sues you, and if with the help of your documentation, if you are able to prove that the affected shoulder was posterior, then you are saved. Because with posterior shoulder, pulling the posterior shoulder, it is unlikely to develop brachial plexus injury. So it is a kind of loophole in the whole process. Then, as you said, algorithm or a protocol-based management is important. You must shout for help and call as many people, as many experienced people for help as possible. No fundal pressure, no pushing, unless you are ready for your further maneuvers. And there must be a timekeeper who will tell you that now stop with this maneuver, go for the next and next and next. So it was really a beautiful presentation. Once again, I congratulate you and I wish you all the best for your forthcoming elections. And I'm sure all of you are standing with you and you are going to make a wonderful Foxy Vice President. Thank you.
Yeah.
Vaishali, can I ask something?
Yes, madam.
Anybody has done the cesarean in their obstructed shoulder? Obstructed shoulder मध्ये कोणी cesarean केलंय का? Because it is very difficult to push the head inside when the patient is in labor and do the cesarean.
Yeah.
Or otherwise, we have to remove the Purandare's shoulder first and then buttocks and then head.
What they have recommended about Zevinelli procedure, that as soon as you push the head and immediately you need to do emergency cesarean. That is why it's better to do these maneuvers in the OT, where you can take a call, like sir said, without wasting time. Means after 1 second, third, not working, then so you need not go till most of the cases, 99% cases, do not go till you need to do the Zevinelli procedure. Most of them resolve beforehand with these simple maneuvers, and they're really very simple, like macro, but just flex, abduct the legs, and immediately the diameter improves and baby comes out. So they are simple procedures, maneuvers, which can be helpful. Thank
Vaishali,
you.
both of you are right. Both of you are right that what she said is when the head is so down, practically out, even after pushing it inside, it will be very difficult to, because no lower segment is identifiable. It is mixed with cervix because the cervix is fully dilated and effaced. So, but your point is absolutely valid that without wasting time, patient should be taken up for a C-section. Now, once you open the abdomen, how to remove the baby, whether it is to be removed with the buttocks, with the breech or with head, depends on personal choice and expertise and experience. But then that is the only option left is by doing an emergency C-section. So,
right, sir. Dr. Manisha, you would like to say anything?
Madam, that was really a very nice visual treat to all of us, demonstrating all the maneuvers. Yes, but God say, I will say that no obstetrician should get this type of problem in their labor room, and they should not have the option to go and do all the drill of these maneuvers. But still, it was really a very nice presentation from your side, and I wish you all the best for the coming elections. Yes, thank you.
Thank you.
Well done, Vaishali.
Thank you. Sane madam, would you like to add any few points?
Mute केलं. She's muted herself.
Madam, mute वर आहात आपण.
Sorry. When that such time comes, we are in such a mess that the things we forget what to do, what not to do. So it's a better revision today we had with all the videos. So thank you so much, and all the best to you for your coming elections.
Thank you, madam. Thank you so much. Thank you. Aarti, we can proceed.
So much, ma'am. So with this, we go on to our second topic for today. I would request Meenakshi Deshpande madam to kindly introduce our chairpersons. Meenakshi ma'am.
Aarti,
Meenakshi madam
Dr.
has
Meenakshi,
logged out.
Yeah, I was talking with some persons. One phone call had come. I'm here only.
yeah.
Yes,
So,
ma'am.
yeah.
Ma'am, you can introduce
Welcome,
our
Dr.
chairperson.
Nagina. You are here, no? Hello. We welcome
Yes,
Dr.
ma'am. Yes,
Nagina
ma'am. I'm here.
Naidu. Yeah.
Yeah, I'm here.
Treasurer of Chandrapur Obs-Gynae Society and organizing treasurer of AMOX 2025. She is the honorary joint secretary of IMS EGP MS 2324. Also WDW co-chairperson in IMA Chandrapur. She was also the honorary secretary of IMA Chandrapur plus secretary of WDW. WDW is the Women's Doctors Wing, and she was the past joint secretary of Chandrapur Obs-Gynae Society. In IMA Mahayuthicon awardee for the year 2021 to 22. And of course, the IMA Maharashtra State awardee for the best honorary secretary of the local branch. She was also the IMA National awardee for the best honorary secretary of the local branch. And further to that, she's a very good friend of mine and we really gel with each other very well. So I would like to request Nagina also to come over to Pune in the December month. And of course, we will be coming over to Chandrapur to meet you all in the month of February.
Sure, ma'am. Very humbled that you had invited us, and we also humbly invite you for the same. Thank you so much for the intro.
Yeah. Second chairperson. Yeah, Dr. Sarala Agarwal. We welcome you, madam, to this cutting edge webinar of POGS. Presently, she is the treasurer of Chandrapur Obs-Gynae Society and also the organizing treasurer for AMOX 2025. She is presently the vice president of IMA Chandrapur. So we welcome Sarala Agarwal, madam, and wish you to start the session. Dr. Aarti, you can take the session forward.
Yes, ma'am. I would request Nagina madam to kindly introduce our speaker for today.
Ma'am, regarding introducing the speaker, it will be like introducing our own mother, COGS. As a child, we are not at all in a position to as such introduce this lady of COGS. She is actually the president of COGS this year and also the organizing chairperson for the AMOX 2025. And madam is the one of the most important reason that we got the AMOX 2025. And we're very fortunate to have her in our society. Along with that, madam is the West Zone coordinator. With that, madam have lots of awards in her credit. And with this, I say कि introduction के लिए pen drive भी कम पड़ेगा madam के. I'm very humbled that I'm introducing her. Thank you so much.
Thank you, Nagina, for those kind words of introduction. I am really blessed to have you all as my members of COGS, and you all are my driving force of COGS. Thank you. Can I share my screen?
And with that, even also we wish Vaishali madam all the best. And as usual, we love your curls. So we wish you should come successfully. All the best, ma'am.
Thank you, Dr. Nagina.
Yeah, ma'am.
Yes. Can I share my screen?
Ma'am.
Okay. Yes. Is it visible now?
Yeah.
Yes, it is.
Okay. Yeah. Yes. Good evening to each and everyone present here. At the outset, I would like to thank POGS, Dr. Vaishali Chavan ma'am, to giving me the opportunity in this webinar. The topic today is again one of the most important one, that is intrapartum care for the joyful motherhood. We all know that intrapartum care is also one of the strongest pillar of the respectful maternal care. Now, talking about the intrapartum care, actually this concept, it rests on the three pillars. First one is providing optimum pain relief, that is the judicious use of the analgesics and the antispasmodics. Then ensuring that the patient is having adequate uterine contraction and the active management of labor is being established. And of course, the close clinical monitoring of the labor events. And the most important is maintaining a partogram. So as we go back, the history regarding the active management of labor, there was a concept advanced by the Irish School in 1973. O'Driscoll and his colleagues, they reported that whenever the active management of labor is being managed by different protocols, it results in shortening the labor, improving the obstetric outcome, and it also lowers the cesarean section rates. Now, talking about the active management, yes, how the active management is useful, because it prevents infection, dehydration, ketosis, exhaustion of the mother, dissolution in the mother, and of course the fetal distress if the labor is prolonged. Now we all know about the partogram, which is one of the important part of our obstetric practice whenever the patient goes in labor. And we know that the horizontal line, it represents the time elapsed, and the vertical line collaborates with the cervical dilatation. So I am not going upon its details. So how do we select the patient for the intrapartum management of labor? So this patient, they should not have identifiable medical or obstetric complication. Then the patient with primary and single-term pregnancy with cephalic presentation, with spontaneous onset of the labor, they are to be selected judiciously. Gestational maturity, they should not be a preterm labor. Of course, the maturity should be around 37 to 41 weeks of gestation. And on admission, the NST, it should be reactive. Again, we all know the active phase of labor starts whenever the patient's cervical dilatation is 4 centimeters or more and the cervix is 50% at least effaced. So these are the selection criteria. The primary or multi, she should not be preterm, low risk patient. Presence of anesthetist and the neonatologist should be ordered. Proper consent of the patient should be always there. And the patient should be in the active phase of the labor. Again, talking about the patients which were not considered for this intrapartum care are these high-risk cases like APH, preeclampsia, diabetes complicating the pregnancy, poly and oligohydramnios, CPD, malpresentation, and if the patient has landed up in pre-labor rupture of membranes. In this patient, we should consider, but it is guarded. So this medication protocol for the intrapartum care, it begins as soon as this patient, they enter the active phase of labor. So we have already discussed the uterine contraction should come at a frequency of at least 3 per minute, and they should last for around 35 to 45 seconds. Cervical dilatation, it is 4 or more centimeters, and cervix effacement is more than 50. Head should be engaged. There should be no clinical suspicion of CPD, and patient may have show. Now, talking about the medications which are used in intrapartum care. As per the protocol, a combination of drugs which are used to provide pain relief, that is labor analgesia, which are in combination used with antispasmodic, which can help us for cervical softening and dilatation to moderate, drive the delivery. Now, what is the advantage of this protocol? They provide with benefits of drug synergism, and at the same time, they restrict the dose of drug to the minimal amount. And with this, we achieve a progressive labor. And at the same time, there is safeguarding of the mother and her fetus against any major drug adverse effects. Now, how does we go? Again, one point is we start an IV with the ringer lactate. The speed will be about 20 drops per minute. Then ensure that the pains are optimal, that is 3 to 4 in 10 minutes. Yes. And if necessary, if the pains are less, we can add 2 units of oxytocin in the drip or give pramipros to enhance the leg. Then we dilute an ampoule of 30 milligram of pentazocine or Fortwin, and similarly dilute an ampoule of diazepam in 10 ml of diluent. And we administer 1/5 of each drug, that is 6 milligram of pentazocine and 2 milligram of diazepam, slowly in bolus and from the tubing of the infusion line. Now what happens? With this administration, we have to very closely monitor the patient, observe the progress of the labor by charting maternal and the fetal parameters every hour. And earlier also, if there are some indications, and we assess the progress of labor on the basis of cervical dilatation and the descent of fetal head. And we document periodically this on and chart it on partogram. Again, when this patient are in advanced labor and the fetal head starts pressing down on the pelvic floor, and if the patient's
Ma'am, I think the video has got stuck. I
during
think
labor,
we are having a
proven obstetric, the proven and obstetric analgesia is epidural. But in places where in the remote areas where the epidural cannot be provided, yes, tramadol, non-opioid analgesic, they can be also used as labor analgesia. Again, talking about ketamine, it is a dissociative anesthetic. It is gaining popularity, but for the pain relief. But then we have to monitor this patient very closely and distinctly. Now, how to assess the analgesia during the labor? The scale can be plotted. If there is no pain relief, then we document it as 0, mild pain relief 1, moderate pain relief 2, and if she have excellent pain relief, then we chart it as 3, score 3. Now, talking about the clinical evidence of this intrapartum analgesia. Many studies were conducted. It was seen
we're having some technical difficulty. I think Manisha ma'am's network is not stable. Manisha ma'am, just sorry ma'am, sorry to interrupt you. Can you just see if your network is stable, because your video is getting paused intermittently?
Okay, now let me see. Now, is it okay?
Yeah, it's okay now. Yes.
Okay, okay. Now we are having issues here since 2 to 3 days of internet. Yeah. So with this study, they have come into the inference that the cervical dilatation was significantly faster in the cases group. Again, duration of the stage of labor, it was also shortened, and the pain relief score was also better in the study group. But when complications in both groups were plotted, the side effect was observed more in the this study group, because it may be that due to the drugs which were used. So the result is the rate of cervical dilatation was very much significant in the case study group. The duration of active phase of labor was also reduced. The duration of second stage of labor was also reduced in this study. And majority of the patient in both groups, they delivered vaginally. Again, 86% patient in study group had pain relief as compared to 22% in the control group. And this data is statistically significant. The cases had significantly more drug-related side effects like nausea, vomiting, drowsiness that subsided after 12 years. And there were no significant fetal or neonatal complications in the either group. Now, again, the various studies were compared, and it was seen that the antispasmodic, which were used during the first stage of labor for ripening the cervix and accelerating the cervical dilatation by an average of 74.34 minutes. So they come with the conclusion that using this antispasmodics has lessen the time interval of even the second stage of labor and also the third stage of labor. Now, again, they were prospective randomized trial, and they have seen that when the weltamide bromide, which we commonly call as epidocin, which is very well known, that were introduced in the patient, and it was seen that the median time for complete cervical dilatation to the delivery was 20 minutes in the groups which received this weltamide bromide and 25 minutes in the group that did not receive the drug. So the conclusion was that weltamide bromide, it significantly shortens the second stage of labor in nulliparous women. So these are the side effects of weltamide bromide. We all know, but they are often manageable. So they found that no statistical significance was found when adverse drug reaction was compared between the age group of 18 to 25 years and 26 years also. So ADR reported were irrespective of the age of the patient, and no life-threatening or severe form of adverse drug reaction was noted in the either group. This was also one of the study conducted. Again, comparing rotavirine with weltamide bromide, they came that the study was compared with the patient, and they came with the conclusion that headache and cervical tear were less in the weltamide group. So now, talking about the advantages of the intrapartum care and the labor analgesia, yes, first important is it shortens the labor with substantial pain relief. Then it causes the significant amnesia of the painful events of the labor. Average blood loss was also less in this patient. The duration of all the 3 stages of labor was markedly reduced in this patient when the drug was used. Obstetric management is often simplified when we go through the different protocols in managing the patient in labor. Again, there is very lowering of the incidence of the operative deliveries. Again, neonatal morbidity, it was similar as equal to the control group. So with this, I come to the end of talk. And I again am very thankful to POGS and Vaishali Chavan madam for giving me this opportunity. Thank you, madam.
Thank you, Dr. Manisha, for your talk on this important topic and updating us about it. Intrapartum care is important to prevent mortality and morbidity, not only in mother but also in the newborn baby. Thank you for explaining everything and all the aspect of it very comprehensively. It was a good revision for us. Thank you.
Yes, thank you. Thank you, ma'am. Thank you.
Welcome.
May I say something? Hello?
Yes.
Yes, sir. Yes, sir.
Yes,
Yeah.
sir.
Dr. Manisha, it was an excellent presentation. I felt almost as if I was back in my postgraduate class, and complete with O'Driscoll and Philpott and alert line and action line. It was just perfect. You
Yes.
have very beautifully pointed out that medical management of as labor analgesia can be as effective as anywhere else. In the city where I practice, epidural analgesia has become like a fashion. Every other patient wants epidural analgesia, and they are blissfully unaware of the potential complications also. I'm not saying that epidural analgesia is bad, but judicious use of these opioids, non-opioids, ketamine, they can yield equally good results. My guru, Professor Dr. Shirish Daftari sir from Mumbai, has been a very strong proponent of medical management of painful part of labor, and he used to conduct workshops in different cities and different hospitals. So thank you. That was a beautiful presentation.
Thank you, sir. Sir, because this is one of the bundle of respective maternal care, what we say.
Absolutely.
And nowadays, we also ask the companion to accompany
Yes.
the patient in
Yeah.
the labor room whenever she lands up in second stage of labor. That is one
Yeah.
of the point. It also shortens the second stage of labor, what we have seen in our rural practice there. We practice in the periphery where not all the time the anesthetists are available to us. So we have to be very vigilant, very thankful, and do our procedures and the patients.
Very involving the patient and her companion
Yes.
in the decision-making process also
Is
helps a lot.
Yes, sir. Yes.
Thank you very much.
Yes. Thank you, sir. Thank you, sir.
Respectful labor, very beautifully covered, Dr. Manisha. Like sir said, you really taught it. You know, we made it so very interesting and so simplified in presenting all those data, and the way you presented. I'm sure all of us, all the delegates, all the attendees you have logged in have definitely benefited with this. The way you have actually taught it to us. So
Yeah.
thank you very much. It was a very, very good presentation.
Thank you.
And
Thank
we
you.
can see why you are the leader of Chandrapur Association, how they look up to you. Not only them, entire AMOGS, entire Foxy looks up to you. You're a great leader. And under your leadership, AMOGS, I'm sure, is going to be a grand success. So
Yes.
we look for it's huge mammoth amount of work, and I'm sure it is going to be a great success.
But you all are coming to Chandrapur AMOGS. I would like to take this opportunity again to invite you all with open hands, sir, and all of you
Yes.
to come down to Chandrapur for this
Certainly.
academic feast
Thank
of
you.
our and also our hospitality. With folded hands, sir, I request you to please come.
Definitely. Yeah.
Thank you.
So, thank you so much.
Yes, sir.
Thank you for the invitation. We will
Yes, thank you.
100% be there.
Yes, thank you. And you also have to participate in our cultural event. I know, Vaishali ma'am. Yeah.
मनीषा, तुला काय मदत हवी असली तर सांग आमच्याकडनं.
अगदी मॅडम, बिलकुल तुम्ही आहात ना, हक्काची माणसं आहात, मीनाक्षी मॅडम.
आम्ही हक्काची माणसं आहोत
अगदी
त्यांची.
घरची माणसं आहात तुम्ही. अँड यू आर जॉईनिंग
कल्चरल बसवायचा असला आणि काय मदत हवी असली.
येस मॅम, बिलकुल बिलकुल. नक्की नक्की. कारण तुम्ही बरोऱ्यापर्यंत आले आणि नंतर निघून गेले. आता चंद्रपूरमध्ये या.
आम्ही नागपूरचा पाऊस पण अनुभवला, जोरदार पाऊस.
हो, तेव्हा अगदीच
अमरावतीचा सर, अमरावती.
नाही, चंद्रपूर आहे.
चंद्रपूर आहे. तेव्हा पण पाऊस होता जेव्हा तुम्ही लँड झाले रेल्वे
तेव्हा
स्टेशनवर, मला वाटते.
परत जाताना सुद्धा नागपूरला तुफान पाऊस होता.
नागपूरला,
हो, नागपूरला पण पाऊस होता. करेक्ट.
येस मॅम.
अँड
मीनाक्षी मॅडम, तुमची कल्चरल एंट्री आम्हाला हवी आहे.
येस.
कशामध्ये?
वैशाली मॅडम,
अमॉक्सला ना? नक्की.
पीओजीएस आणि वैशाली मॅडम आहेच की.
एखादी पेशवाई राणी म्हणून करा परफॉर्म.
आमचं क्वीन्स ऑफ इंडिया आहे थीम. महाराणीज ऑफ इंडिया. यू कॅन टेक एनी ऑफ दिस अँड गो विथ दॅट.
Wonderful theme.
It's
Yes,
a very
good thing.
thoughtful
Maharanis
yeah.
of India.
Yes, yes, yes.
Queens of
Because
India.
we are queens, na? Vaishali madam, we
Yes,
are the
you are
queens.
correct.
Maharanis of India or Queens of
Yes.
India.
आम्हाला
Yeah,
एक
we
क्वीन
are.
सोपवून द्या.
Maharanis of
Queens.
India is our.
आम्हाला एक क्वीन सोपवून द्या. तिला आम्ही पुढे आणतो.
Yes. And your cultural program, the performance you did, my God, at Amox. I think
Yes,
even
yes.
Yash Chopra mustn't have imagined that it can be, taken off this
But
way.
our team is not going to
Yes.
participate in competition.
Yes.
We will
They
be.
will win. Chandrapur will win if they participate.
No, they
No,
will
no,
not
we will not be
participate.
participating. We will be only
Yes.
performing, ma'am, but we are not participating in the competition. We are the
Competition.
host. Yeah, we are the host. Yeah.
Very
It's so
gracious.
nice of you.
They will present their talent, but they will not participate in
The
competition.
competition. Yes.
Very,
Vaishali
very
ma'am,
talented. Highly talented.
yeah, Vaishali ma'am, we want wholehearted support,
Yes.
and this is the best time to appeal to everybody also, I'm sure. So please come down.
We will be there.
Yeah.
And
Okay.
we are here to
Thank you
with
so
you,
much.
Vaishali madam.
तुम्ही सगळ्यांना
Thank you
POGS
so much.
एंडोआर्टला या आणि तुमच्या बरोबर आणखीन पण डॉक्टरांना घेऊन या.
अगदी मॅम.
सगळ्यांना मजा करूया तिकडे पण.
हो.
आमची कल्चरल नाईट हे आहे, कल्चरल नाईट आणि अवॉर्ड फंक्शन
हा.
शनिवारी रात्री.
अच्छा.
दिवसभर वर्कशॉप्स आहेत आणि रात्री कल्चरल नाईट
21st December.
21st.
21 ला.
Okay, bye bye.
बाय.
काय आहे ना अगं मनीषा, सगळे ना फॉक्सीची लोक चालले त्या सिलिगुडीला.
हो.
आपण इकडचे सगळे आमच्या पुण्यात
मॅडम मी पण आहे. मला पण बोलवलंय सिलिगुडीला. मी पण आहे तिथे.
तू जाऊ नको.
ऑलरेडी त्यांनी मला दिलेलं आहे.
महाराष्ट्रातच राहा.
बाकीच्या येतील मॅडम, नक्की येतील.
Aarti madam is very upset with all of us.
Yes.
Going to Siliguri.
ना प्रियांकुर नी आधीच सांगितलेलं मला, मनीषा मॅडम आपको आना ही आना है. हाँ रे, आना ही पडेगा. बट आय वॉज नॉट नोइंग दॅट POGs ऑल्सो इज हॅव्हिंग
सिलिगुडीला जाणारे सगळे फितूर लोक आहेत.
अगदी बरोबर.
कारण तुम्ही क्वीन्स ऑफ इंडिया हे करणार आहे ना, तर त्याच्यात फितूर लोक कशी बाहेर पडतात.
मॅडम तुम्ही नॅशनल प्लॅटफॉर्मवर आहात आरती मॅडम. प्लॅटफॉर्मवर नाही, नॅशनल.
आपल्या राज्याला सोडून फितुरी कशी करतात बघा.
म्हणजे तुम्ही ठाकरे सेना आणि शिंदे सेना असं चाललेलं असतं.
Aarti, will you propose vote of thanks? Then we can continue chatting.
Yes. Thank you so much, ma'am. We would thank all the eminent speakers and the chairpersons, of course, the guests of honor who have taken the time to be here with us. And of course, we would like to thank all the delegates who have joined in for this academic fest. We would like to thank RSV, everyone who has basically been part of this and made this academic feast a success. Thank you so much.
Aarti, so nice of you to organize the small Aarti, the young Aarti I'm referring to. She's our toddler and upcoming very fast. She manages show really well. So thank you, Aarti, for everything.
Yes, thank you, Aarti.
She's very good, and she's with us in the imaging workshop also for this POGS Endo ART.
Very
Aarti,
sincere.
you can invite everybody from your behalf also.
आरती तू डान्स करते.
मॅडम आपण जरा क्लोज करू मग.
क्लोज करूया.
Aarti, yeah, special thanks to Aarti Evle and a very young, very sincere gynecologist imaging specialist. Thank you to Dr. Charu Joshi sir, Dr. Sane madam, Dr. Manisha, Dr. Manoj, for Bandara OBGY Society for being with us in this webinar, Dr. Kalpana, Dr. Nagina, Dr. Sarla. And of course, thank you to BSV for being part of this academic. And thank you all. Your presence has truly enriched the webinar and it was very, very educated. Thank you.
It was a beautiful experience. Thank you.
Thank you so much, ma'am.
Yeah.
Thank you, sir.
Mr. Aman, can we go offline?
Yes.
Yes, ma'am.
Are we offline?
Recording stopped.
Yeah. Now we can talk.
Yeah.
Yes.
गेली का आरती गेली.